So today we are very privileged to have our eminent speakers for tonight. That is Dr. PC Manoria, sir. Very good evening, sir. Who is the director of Manoria Heart and Critical Care Hospital, Bhopal. Over to Dr. Manoria, sir. Over to you, sir.
Can I share the slide?
Yes, sir. I'll stop sharing then.
Are you able to see the slides? Are you able to see the slides?
Yes, sir.
Okay. So, good evening, everybody. For the next 10 minutes, I will be talking on paradigm shift in screening and management of cardiorenal metabolic syndrome and what is the role of MR overactivation. Now, it's very important to remember that there is a close cross connect between heart and kidney, and so also heart failure and CKD. Worsening heart failure worsens CKD, and worsening CKD worsens heart failure. And therefore, heart failure and CKD should never be treated alone. The cardiorenal continuum should be treated as a whole. And don't forget, targeting kidney disease triggers benefit for heart failure and vice versa. And one must think that heart and the kidney as a spousal relationship. And so what's good for one is generally good for the other, and they try to help each other. And now a metabolic component is also added because obesity and diabetes not only adversely affects the kidney, they also adversely affect the heart. And that's why we talk of cardiorenal metabolic continuum. Now all of us know CKD is a progressive disease. There is till date, there is no magic bullet which can reverse CKD to normal. But nevertheless, we have 3 revolutionary therapies which slow down the trajectory of CKD, slow down the declining EGFR, and postpone dialysis by 10 to 15 years or so. The first in the series came with RAS blockers in 2001. Then we have SGLT2 inhibitors after the credence, DAPA CKD and EMPA CKD. And finally, the non-steroidal MRA proteron with the Fidelio DKD, Figaro DKD, and the Fidelity trial, which we are going to discuss. The beauty of all these molecules is they produce incremental benefit on top of each other. So if you use RAS and then SGLT2 inhibitor, there will be incremental benefit. And now you add finerenone, there will be another incremental benefit. And that is the beauty of all these 3 agents. But the biggest problem in CKD is that early stage CKD is often missed. And when diagnosed late, the patient gets little benefit of CKD modifying drugs. And if you look at this ADD CKD study, you can see 85% of patients had EGFR assessment during the 15-month period prior to the study participation, but only 47% has UACR, which is not at all permissible. So why we are so much concerned about UACR? CKD must always be diagnosed by UACR and EGFR and never by EGFR alone, as we see in many patients. Now, if you look at the all-cause mortality or the CV mortality, the normal range of UACR is 0 to 30. Even when the UACR is within the normal range, you can see the hazard ratio for all-cause mortality, the hazard ratio for CV mortality is 1.77, which means the cardiovascular event starts rising even when it is normal. Once it reaches microalbuminemia, which is 30 to 300, there's a further increase in the hazard ratio. And after 300, of course, more increase. But when you look at the EGFR in the all-cause mortality and the CV mortality, only when the EGFR falls below 60, then only the all-cause mortality and CV mortality starts increasing. So that is the beauty of UACR. Now again, if you look at the the UACR, as the UACR rises, even in the microalbumic range, you can see 41 events per thousand. In fact, UACR is a red button or a red flag of the cardiologist, and once you have a microalbuminuria, you should try to execute all possible therapies to minimize cardiovascular disease. With further increase in the UACR, you can see there's a progressive increase in the cardiovascular event to the extent is more than 1,000, you can see is 82 per thousand. On the other hand, when microalbuminuria increases, initially there is only little increase in the renal events. It's only when it crosses 1,000 you start increasing the renal events. So that you must keep in mind. And all of us know albuminuria and fibrosis are very closely related, and both are highly prognostic markers for kidney failure, as you can see on this slide. All guidelines across the globe recommend UACR, EGFR at least once in all diabetic patients, and those who have microalbuminuria maybe twice, and if the circumstances demand, even more often. So the big message is UACR is a biomarker. It's not only a biomarker, it's target for the cardiologist to decrease CV events, because the early stage of UACR elevation, it is the cardiovascular disease which is hit and not the CKD events. So for several years, we have been chasing BP target, LDL target, glucose target, anti-proBNP target. Time has come. We must also chase UACR targets in patients with CKD, those diabetes who are admitted to the cardiology department because of some other reasons. You must get a UACR done, and we must utilize UACR as an additional target for cardiorenal protection. And the goal is greater than 30% if it is more than 300 as per all guidelines. Now let's look at one of the patients. The current burden as per 2023, we have 101 million diabetic patients, and it is projected that by 2045 we will have 124 million, but it seems that the number will be much more than as it's projected, as we saw in 2023. And large number of patients, this is an old data of 2017, of diabetes have CKD. So CKD and type 2 diabetes is a high burden in the Indian context. Now let's look at this individual. Is a 57 years Mr. Raj, old patient of diabetes, diagnosed 10 years ago. HbA1c is reasonable, 7.4, with standard of care for glycemic therapy. Blood pressure little higher, 138 by 84. And aside from the usual ailments, he is asymptomatic, but his physician wants his kidney health to be maintained. So now when he gets his EGFR done, he falls in grade 2 because the EGFR is 60, and he comes in the low risk. But moment where UACR is 352, so his risk tremendously increases, and this is the value of UACR. Now, CKD and CVD progression in diabetes is driven by combined effects of metabolic, hemodynamic, and inflammatory and fibrotic factors. So we have the first driver is hemodynamic, and it is the intraglomerular hypertension which is more important rather than the blood pressure in the arteries. If you have intraglomerular hypertension, you will have more proteinuria, and CKD will progress more rapidly. So our target is intraglomerular hypertension. The second factor which progresses CKD is metabolic factor, poor glycemic control. And the third, which has not been targeted before the phenomenon, was inflammation and fibrosis. And all these results in kidney fibrosis and cardiac fibrosis, which result in progression of CKD and CVD. The kidney fibrosis occurs because there are tubulo-interstitial damage and inflammation, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and fibrosis also occurs in the myocardium. So we have myocardial fibrosis, atherosclerosis, stiffness in the vessels, and also a lot of calcification in patients with CKD and ventricular hypertrophy. So the current therapies or patients with CKD and T2D primarily target not only the hemodynamic factors but also the metabolic drivers of CKD. So if you want to target the hemodynamic factors, which is now targeted by mainly by ACEI and ARB, they dilate the efferent arteriole or decrease the intraglomerular pressure. The other agent, no doubt, will decrease blood pressure, but the agent of choice are RAS blockers, dilate the efferent arteriole and decrease the intraglomerular pressure. SGLT2, they constrict the efferent arteriole and decrease interglomerular pressures, and they have other actions also. And these anti-diabetic agents also produce good glycemic control and also decreases CKD. Inflammation and fibrosis has not been targeted till Regeneron came into clinical practice, and this is also a very, very important factor. So we now have a holistic approach for CKD treatment targeting all these different pathways, which not only slows down the progression of the heart disease but also kidney disease. So these agents provide a dual benefit. They benefit the heart as well as the kidney. Whatever the agent you are using, whether you are a RAS blocker, SGLT or Regeneron, or now the GLP-1RA also, which has the flow trial has been prematurely terminated in Perth. Now, if you look at the RAS blocker, as we say, efferent arteriole dilation, SGLT2, efferent arteriole constriction, and many other factors, and Regeneron, inflammation, fibrosis, and GLP, the trial has been prematurely terminated flow trial, and in times to come, this will become the fourth pillar. So the key points are individuals with diabetes are tenfold more likely to progress to ESRD than those without diabetes. All physicians, practitioners must remember many patients may not reach ESRD due to premature death from CKD. Cardiovascular disease is the commonest cause of death in CKD and not renal disease. Only the lucky ones reach the end stage kidney disease. Early CKD stage is picking up is very important. It should never be missed. And if diagnosed early, managed appropriately with all these drugs, this progression can be slowed down to a great extent. Dialysis can be postponed by several years. We had RAS blockers in 2001, then SGLT2 inhibitors for patient for CK to check the progression, and OMRO activation, which contributes to inflammation and fibrosis, can now be targeted by Regeneron, and therefore Regeneron has initiated dawn of a new era, and this provides not only benefit to the kidneys, it provides benefits to the heart. Thank you very much for your kind attention.
Thank you so much, sir, for your insightful talk and setting the stage for other speakers discuss. As we move forward, may I request all the joinees to post their questions in the chat box so that we can take it up in this Q&A session.
Before we have
So,
Q&A session, Dr. Gupta, what is the best formula to calculate EGFR and what are limitations of serum creatinine for the physicians?
So the best recommended formula for calculating EGFR is the MDRD formula that has been standardized. Although it's not been standardized in India, it's been standardized in other Southeast Asian countries, and there are standardized equation for this. And creatinine definitely has got a drawback on specifically patients who are on extremes of age and extremes of body weight. So creatinine is not a ideal because creatinine is also secreted from the kidney tubules other than being filtered in the glomerulus. It's not an ideal candidate for measuring GFR, which we know the gold standard is inulin. So it's important that we understand that calculating the GFR in inulin is impractical. Even doing a DTPS scan with is also an impractical and highly costly study. So the one of the best method in doing measuring the EGFR in all spectrums of ages and body weight is a combined MDRD equation, which is available for incorporating creatinine as well as cystatin C. This is readily available in the app. incorporating creatinine, cystatin C, and age. That is by far the most accurate estimate of GFR. We also have to know that even with this estimate, the GFR is actually at a standard deviation of plus minus 15 to 20 in any age groups. It's more in extremes of ages.
The other issue is, suppose the patient presents for the first time with UACR 2000 or above 1000, 1500. Will you start with one drug, two drugs, three drugs, or all the three drugs? Follow a step care approach, or use two drugs or three drugs?
It the UACR is
UACR
A3
is very high,
category.
1500,
Yeah, it's the
2000,
A3
which then.
category, A3 category of UACR. So whenever there is an ACR category of UACR, the baseline drug that you have to start is an ARB. We use more ARB than ACE inhibitors for obvious reasons. We have more experience with ARB. Type 2 diabetes mellitus has more experience in ARB as compared to type 1 diabetes has more experience with ACE inhibitors. So ARB is the baseline drug that you have to use start from the beginning, and possibly SGLT2 inhibitor as well as the first drug along with ARBs as well. Now, for to start initiate finerenone, you have to set the stage. You have to be very sincere with the term of maximum tolerated dose of AC or ARB. So we need to up titrate the ARB to the maximum tolerated doses. For telmisartan is 80 milligram once a day. If the patient is tolerating that without an increase in hyperpotassium level or less than 30% increase in decrease in GFR, still the proteinuria is persisting. Most of the cases it will persist. Then probably in my protocol on third or fourth visit, I add finerenone.
Previously, in heart failure, hypertension, diabetes, we used to follow a step care approach. But now we realize this combination should be initiated yearly. So, what is your viewpoint on CKD? Because CKD progresses relentlessly. We don't target with multiple options.
Yeah, CK, it is of course multiple option, but you have to see the time frame. If you do not up titrate the AC and ARB to the maximum tolerated doses, in my clinical experience, the effect of finerenone is suboptimal. We have to give the patient the benefit of AC and ARB first. If you want to start the three molecules together, then the hyperkalemia risk of hyperkalemia cannot be estimated by which molecule, ARB or by finerenone. So my stepwise approach is to start the dose of ARB, then up titrate it, see the patient on every 2 weeks or 1 month interval, and once the AC maximum dose of ARB is tolerated, by second month after he first visits me, he will be put on finerenone in a much stable condition.
Are there any questions from the chat box? Otherwise, we have still more.
Yeah,
doubts.
Dr. Manoria, I have to join another session. I have to leave.
Are there any questions in the chat box?
No, sir. We don't have any questions in the chat
So,
box.
other issue which we face, Dr. Sen Gupta, is that sometimes we have patients of diabetes, CKD on all the three drugs. Now the patient develops hyperkalemia. So what do you do? Stop all drugs or stop A, B, C? What is the protocol, and what is the protocol for reinitiation? That is another problem we face.
Exactly. So it all depends. It's an individualized approach. When the patient is developing hyperkalemia, I keep on monitoring my patients from a distant interview type of thing. I keep on monitoring my patients every 2 weekly. Once I start finerenone, it's slightly different from what they have recommended, but I find my program, my method to be quite useful. Initially, for the first month, I see them every 15 days. Now it's been always seen in the studies, the risk of hyperkalemia is highest when there is a GFR dip in with finerenone as SGLT2 inhibitor. We all know that there will be a GFR dip with use of SGLT2 inhibitor and finerenone. Now this period is the highest risk of hyperkalemia, and the patient is in high risk of developing subsequent hyperkalemia if the patient develops hyperkalemia during the initial period. So I get an idea whether the patient is tolerated a low GFR, no hyperkalemia, then probably I'll monitor him every 4 months or 5 months, every 4 months or 5 months that are given in the protocol. But even if the patient develop hyperkalemia in the initial first 15 days or 1 month, I will monitor him more closely. Once he has developed a hyperkalemia more than 5.5, I'll transiently reduce the finerenone if it's on 20 milligram, or if the blood pressure is, sometimes the blood pressure is very optimally controlled with AC and ARB. So I will probably, if the blood pressure is optimally controlled, I'll slightly reduce the dose of AC and ARB as well, keeping the finerenone same. So when there is a drastic reduction of UACR with finerenone, I usually do not try to mingle with the dose of finerenone. I'll simply add some potassium binder, manage the diet well, possible, if possible, give some diuretics. And of course, in our clinical practice, is very important to understand the role of sodium bicarbonate, which we frequently give in many patients with chronic kidney disease. And sodium, increasing the dose of sodium bicarbonate in my clinical practice has significantly reduced the incidence of hyperkalemia. Now we all also know that the ZCS, zirconium cyclosilicate, has been launched in India. That also, although is a very costly drug, it can be used co-prescribed with this molecule for some patients who need to be on this molecule but had persistent hyperkalemia. Other than being more palatable as compared to the potassium binding resins, they have less GI side effects as well.
The other issue is the finerenone is for type 2 diabetes recommendation as per guidelines and as per the trial. Do you use it as an off-label indication for type 1 diabetes and CKD proteinuric?
So, very to be very frank, we see very less number of type 1 diabetic patients. I have not yet initiated any patients on type 1 diabetic, but I have to tell you, I have off-label use on some non-diabetic CKD patients who having a refractory proteinuria in spite of best available medication that we can give, and we have encouraging result, that I can tell you.
Last issue, suppose a patient is on CKD, he's on finerenone and maybe on the other drugs, he develops heart failure. So heart failure symptomatic was a contraindication in the Fiderio
Exactly.
and Figario
Yes.
trial. So what do you do?
Yes.
Continue with finerenone or switch on to the spironolactone? What is
So
the...
obviously, it's a very nicely framed question. So I think for an acute decompensated heart failure, spironolactone is still a better drug than finerenone, especially the patient is high, if the patient is hypertensive.
That's okay, but the problem is, will you stop finerenone and switch to
Yeah,
other
temporarily
heart
I tide
failure
over the
therapy in aldactone
yeah,
or...
yeah. Temporarily I tide over the crisis, and then possibly after discharge, I'll go back to the baseline regimen that I have used.
Some other day we'll have
Yes,
more questions.
absolutely.
So, thank you so
This
much,
is
everyone. And sir, like we don't have any questions in the chat box, so may I request one final concluding remarks from all of the three speakers? So, over to you, Dr. Manoria, sir.
Biggest problem in our country, rather across the globe, is people do not measure UACR. If you don't diagnose CKD at an early stage, all these drugs are going to provide minimal benefit. Suppose you diagnose CKD at 30 or 35, the benefit will be minimal. So we must widely percolate, measure UACR and EGFR. UACR is also very, very important, not only for the nephrologist, they use routinely, but also for the cardiologist. Because many diabetic patients get admitted for some other reason, maybe suffering from proteinuria, UACR, maybe micro or sometimes macro. So that is the biggest message. The therapies are available but highly underutilized because of failure to pick up early CKD stage.
Thank you so much, sir. So, Dr. Devashi Shah, sir, as Dr. Manoria said about the poor implementation of ACR testing. So, what are the barriers you are facing in your clinical practice, and how can we overcome that?
firstly, what I feel, there is no barrier. In fact, majority of my diabetic patients, they present with CKD and CHF, and the highest bulk is CKD stage 3, and ejection fraction 25 to 35% majority. And in that group, it's my routine practice, on the day one, most of the cases, they were being treated outside. So on day one, I get them evaluated from EGFR, UACR, and all possible point of view. And the practical scenario is that hyperkalemia incidence is very much less, disproportionately higher, I mean, less at a higher rate with this, I mean, non-steroidal MRA, and that is the benefit that in all the CKD CHF combinations, the pillars, I mean, the four pillars, as I told you, that whether you are using ACE, ARB, or your sacubitril valsartan, then comes your question of this MRA and your SGLT2 inhibitor and few cases beta blocker. I mean, this is how we have to intervene, and we have to implement this, and we need to spread this education at an extensive rate. I have to leave now, Ishani, because I have to join another meeting.
Thank you
Okay?
so much, sir.
Okay. Thank you,
So,
everybody, and good night.
good night, sir. So one last question to Dr. Upal Gupta, sir. So like we are having our target dose as 20 mg. So, but we see that we are most of the doctors they are continuing with the 10 mg dose itself. So what are your insights on up titrating the dose from 10 to 20 mg?
So it's always a goal-based up titration. You will see that the 10 mg, many patients will definitely start with 10 mg, but again, it's a matter of constant monitoring. Using finerenone is a matter of constant monitoring. You should be calling the patient for an aim of up titrating finerenone by monitoring the response to UACR, seeing the potassium, seeing the creatinine. It should be readily agreeing to the treatment managed strategy that the next dose should be 20 milligram, if not at upfront you have used. I have not yet upfront, even the GFR is more than 60. I do not use upfront 20 milligram finerenone. But again, I told you, I usually monitor patients at 15 days interval when I start finerenone early. So in 15 days to 1 month, I usually up titrate finerenone to 20 milligram if the potassium is normal. Mostly they are. And of course, the benefit of 20 milligram finerenone in reducing the proteinuria as compared to 10 milligram in my clinical practice is significantly more.
Thank you so much, sir. So we don't have any more questions also in the chat box. So I